Okay, good afternoon, everyone. I will start in 20 seconds.
Hello everyone, I'm Pedro Costa Monteiro. I would like to welcome you to the Planet PCM 5.0. Let me take you to the next level on orthodontics. We are now able to share with you some secrets of this authentic smile design revolution. Let's start with an extra-oral scanner. Directly from your smartphone, you can scan your patient's face. Face-driven orthodontics is the key to ortho diagnosis. In less than 10 seconds, you will have a 3D copy of your patient's soft tissues and full face. Now, let's scan your teeth, gums, and occlusion. Using the new iTero Element 2 scanner, we have a perfect visual impression of teeth and gums. We can detect caries, tooth position, and gum level in less than 2 minutes procedure. Let me design your new smile. Using the DSD app on a tablet device, we can create a confident smile. Based on facial proportions, bone position, and gum level, it is possible to choose the best tooth design for each patient. Finally, just relax and enjoy, while we take control of your orthodontic treatment, dental monitoring. DM is an exclusive and unique app whereby using artificial intelligence allow us to take perfect control of orthodontic treatment. With virtual appointments, we can watch the patient every day, week, or month in virtual appointments using Dental Monitoring Scanbox. And now, after this technological approach, I propose to share with you all the workflow and explore the new trends on orthodontics.
Okay, hi everyone. Thank you for your invitation. Thank you all the doctors for being here with me. It's a great pleasure to be speaking for Russia. I am Pedro Costa Monteiro from Portugal. This is my city, Oporto, and I invite you all to visit us as soon as possible. And if you can come to Oporto, please visit my clinic. It will be a pleasure for me to receive you as doctors visiting our practice. So this is a little bit of my curriculum. I will not lose my time on that. Just explain you that I'm an orthodontist and I'm now full-time practice on Invisalign. These are my social media contacts, and you can take a photo of all of them and you can contact me whenever you want. Usually people follow me on Instagram. It's the best way to speak with me. So if you want, you can just send me private messages and I will answer all of you with all your doubts and try to help you as I can. So today we will talk about phase 1 treatments, talk about children. How do I treat children with aligners? How is my approach? And I hope that on the next 2 hours you enjoy this lesson. And if you want to stop me to ask any question, please, you can interrupt me and you can ask me, or if you prefer, at the end, we can spend some time talking and answering your questions. So, as you know, the world is changing. Everything now is online. So that's why we are here today on an online course. And our kids, this new generation, they just come into the iPads. They are born in this new era, and we have to adapt our practices to all of this. And on the last 3 years, I completely changed my life, and I create my own aligner clinic. I completely stopped doing braces, and I really enjoy it. So I hope I can teach you some tricks and tips on how to deal with children when we are using aligners. So, what is phase 1 treatment? What is the difference between treating a small patient or an adult? It's really different. And according to the American Association of Orthodontists, as you know, a lot of our patients are kids or teenagers. So it makes completely change the way I was thinking orthodontics, because during 15 years, I only treated adults. And now I am quite focused on teenagers and kids. And that is because of these two doctors that nowadays are my friends. They are working with me on my courses. And I will never forget that they changed my life, Dr. Sandra Tai and Dr. Susana Palma. And they told me, hey, Pedro, you are doing a lot of aligners, but you are only treating 20% of your patients because you are only treating adults. So why don't you change the focus and go into small children and start doing aligners? And it's true that my clinic grows a lot every day because of treating children. So, as I was saying, what is the difference between treating small children or a small boy or a small girl or treating an adult? It is really different, because don't forget this. 60% of the facial development is always before the age of 4 years old. And 90% of the upper face just complete the growth before 10 years old. So what about the maxilla? Why should we wait until 13 or 14 to treat a boy or a girl? It doesn't make sense. And as you know, the last bone that stops growing in our face is the mandible. So if we can correct the way she's growing, probably we will have better cases when we talk about adults. So I never forget this amazing orthodontist, Dr. Kokic, that is already gone. And he said, when you treat children, you have to treat them idealistically. When we treat adults, you have to be more realistic, because the adults come what we call the dental baggage. So they have restorations, they have missing teeth, they have problems on caries, they have periodontal problems, they have recessions, they have restorations. So there's a lot of things that comes with an adult. When we talk about children, we can choose to treat them ideal because we have all the options in front of us. So, in what age should a child visit for the first time an orthodontist? And the American Association, one more time, says that between the age of 7 years old is the best time to see an orthodontist for the first time. And when we get the patient in our practice with 7 years old, we have 3 options. Basically, probably sometimes he doesn't need any treatment. So we just have to make a checkup, see if everything is correct, and okay, send him home and see you in 1 year or 2 years. But some of them, we see that maybe he will need some kind of treatment. So is it the moment to treat him? Should we wait more? 1 month, 6 months, 1 year? But if we do this first appointment at 7 years old, we will just fix the patient, and then we will see him every year or every 6 months, and then we will act when it is really necessary. And sometimes we really have a big problem that we need to treat as early as we can. So today we will talk about these patients that we want to start as early as possible. And what kind of problems can we treat in a patient with 6 or 7 years old? So, for example, if we have a crossbite like this one, and if this boy was one of your kids, would you like to see him growing in this bad position? Probably no. So, why can't we act? We should. And I am treating my patients as soon as possible. So if I see an underbite like this or a crossbite, I really want to start the treatment today. Then we have, for example, the open bites related to habits, related to jaw problems, the cross bites that we should also treat. Imagine that in 1 or 2 years, the maxilla of this patient will not grow anymore. So we should begin as soon as possible. Then we have this kind of crowding. Should this child continue growing with this incisor position? Of course not. And don't forget the risk that this kind of patients have of broken teeth because he is in a very bad position. So let's focus on this and see how can we treat this with aligners. Also, when we talk about spaces, is this child in a good condition for growing? No. So should we start? Yes, we should. Then we have the extra or missing teeth that we have to plan how to do it. I will show you today cases where we are treating kids in these kind of problems. Then we have teeth that completely born in a different position. And we have the habits and the open bites that we are also trying to correct them with aligners. So during these last 3 years, what I have learned is that I can treat almost any type of malocclusion with aligners. It can be more efficient and easier than with the traditional approach of using braces. I can give my patients and their parents a very better experience at my clinic, and I do not have problems of compliance in kids between 6 and 12 years old. So the most youngers are really easy to treat with aligners, and I will show you this today. So why should we go on into aligners, and why did I change all my practice when I start treating all my patients with aligners only? And when you talk with your peers, with your colleagues, you see that some of them don't understood how should they speak with the patients. So, for example, these are some of the sentences that you can hear from some orthodontists, because the patient just come in and ask for aligners. And then the answer is, no, you don't want to have Invisalign. You will have to wear it all the time. You're not sure if it will works good or no, so I prefer to put you braces, okay? And the other one said, no, why are you using aligners? You can just use ceramic braces. They are really cool. And then you have another group of doctors that just say, we recommend you Invisalign because we can treat you with the same or better standard of excellence. And we can treat you faster and more efficiently than we could with fixed braces. And this is the sentences that I am using for all my patients. And this is a study of Sandra Tai, which is really amazing, because when any orthodontist starts his Invisalign journey, he has about 1 or 2 cases and he is not very confident. Then he will choose some master where you will learn all the biomechanics behind the aligners. You will understood the system. So you will start recommending aligners for his patients. And then come the digital. When you start using scanners, you will do aligners for all your patients. And this is what is happening to all the orthodontists around the world. And as you know, I have my own master where we have 500 doctors around the world, and everybody is moving into aligners. So it's the best advice I can give you from my experience. And what are the barriers to orthodontists to start using Invisalign? So some of them have some difficulty when it takes to the patient selection. And for me, patient selection is easy. I treat all my patients with aligners. Then another group is not very confident when it takes to clinical manage the aligners. So there you have to do a master, you have to learn how to do it. Another thing is the share profitability, because at the end, Everything is how you manage your clinic, and you want obviously to get income. And I can prove you that you will have less appointments, more time saving, and you will win more money at the end. Then we have the problem of treatment plan, and that we can be speaking on that during 1 or 2 days. So treatment plan is everything, diagnose is everything when it is related to orthodontics. And then we have the patient education and how to convert our patients. We will talk during this presentation about it. So this is my master. If anyone is interested on it, you can just take a picture, send us a message, contact me by Instagram. So what is for me the big change when we speak about phase 1 treatments? Hair-centric orthodontics. This is a new concept that I have been using. And today I will show you many cases of completely change on function. So patients that just are mouth breathers, they have already problems to sleep, apnea, and we treat them with aligners and we solve the function. Then we will talk about TMG and how can we solve a class 2 as early as we can. Obviously, we will talk about mandibular growth and smile arch oriented orthodontics. These are 4 concepts that I want to share with you, and I want to make you think if you can do it in your own clinics and change the way you are treating kids. So let's focus on hair-centric orthodontics. So as you know, if we have a class 2 patient, for example, of 7 or 8 years old, do you think it makes sense to let that patient grow being a mouth breather, don't sleep well, just because the mandible is not in a correct position? And why should you wait until the peak of growth to treat him? Why can't we start treating them at 7 or 8 years old, bring the mandible forward and let them breathe normally? This is function, is life, is much more than aesthetics. And as you know, the form follows the function and the function follows the form. So if I can expand an arch, change the arch shape, create space for the tongue, and let that kid breathe normally, this is the best treatment I can give them. That's why I am treating kids with the mandibular advance feature on my aligners, and I will share with you many cases today. So using the CBCT, we have now the possibility to understand how are we treating our patients and how are we changing the way they breathe. And this is my advice for you. Try to do CBCT to all your patients at the beginning and at the end and see how they are breathing better. And of course, there are now studies that are proving that kids with attention deficit disorders, kids with small IQ scores, kids with obstructive sleep apnea are related with class 2 with mandible on a retruded position. So we should try to treat them as soon as possible. About TMG, you know that if you have a class 2, the condyle is not on the best position. So if you can put it on a perfect position at 7 or 8 years old, I think it makes sense to treat them. And obviously, we will not discuss today if we are getting some growth on the mandible at 7 or 8 years old, but at least we are putting it on a forward position. And this is what I want in a small kid. Bring the mandible forward and let him breathe. And of course, we know that during the peak of growth between 12 to 14 years old, the mandible will grow a lot. But I prefer to start earlier and to let them grow in a better mandible position. And you know that is different between boys and girls. There's a lot of appliance I have been using all my life, but nowadays I prefer to use aligners with the mandibular advancement feature. And the smile oriented. What is this? This is from my friend Christian Coachman. I work him in some projects on aligners, and we are treating small kids using DST and giving them a perfect smile arch from these small ages, and it makes sense. And don't forget that everything we are talking here today has something on science behind. So there's a lot of articles that are proving that if you start changing the arch shape as soon as possible, you will have less extractions on your orthodontic treatments when we talk about treating kids with 14 or 15 years old. Also, because of the function, if you want to have a very good position of your tongue, if you have a perfect arch, it will be easier. If you have constricted arches, it will be difficult. So why should not we start as early as we can? And also about TMJ, what we talked before, there's a lot of kids with TMJ problems in these small ages. So let's treat them. Let's give them the possibility to grow in a perfect position. And this is my kid when he was 5 years old. And because I like to treat them as early as I can, I just teach him how to drive a motorbike on 5 years old. And here it is. So this is 3 more articles that you can read just to understand these objectives that we want on the first phase. So how do we manage this? How do I manage my treatments in so very small patients? And one of the questions that many doctors ask me is, but how do you manage if you start too early? They are on a mixed dentition. And will you do a second treatment? How do you manage this? So it's very easy. Invisalign First allows you to treat with as many aligners as you can during 18 months, so 1 year and a half. After that, we can ask for retention and let him grow on a perfect position. And then, if we need, we go into phase 2 treatment. But this phase 2 treatment is really a small phase because we are always treating class 1 patients. Because on phase 1, if you was a class 2 or a class 3, we have already treated that on that phase. So it will be easier to do a second phase, a small second phase, very easy, just related to small changes on tooth position. So I am doing this protocol. And about the retention, we can use aligners for retention. We can use the Alley appliance for retention. And sometimes we just don't use any retention. And I will show you cases during this presentation. And now, just about marketing your practice, imagine what you can achieve if you have one patient during 10 years in your office. So we start at 6 or 7 years old. We treat them during 1 year and a half or 2 years. Then we do retention, and then we have the second phase at 14, 15, 16 years old. So imagine that while he is under your control during 10 years, you will have all the family coming into your office. And I give here an example of 4 kids from the same family where I start treating the older one, and then comes the other brother, then a sister, and then the other sister, all at the same time, all doing aligners year after year. And this is really great for your clinic. So now I can say that my clinic almost treats families because I start with one kid, I pick up all the kids, and then come the parents, the cousins, and you understand. So, what are the indications for phase 1 treatment? When should we act? So, if we have any skeletal discrepancy, or we just want to change the way the growth is going, we can act and we should act. And for example, if we have space problems and we will not have space for the future tooth that are just need to erupting, we should also do a phase 1 treatment. And then we have the cross bites, the anterior cross bites, the posterior cross bites, traumatic occlusion. So if you pay attention and if you work closely to your pediatric dentist, you will get a lot of cases to treat with aligners. So, Invisalign says to us that everything related to arch design or arch development can be treated with aligners. When we talk about creating space or just crowding solving, it's easy to do it with aligners. If you need to use mandibular advancement on class 2, we can also use aligners. And when we talk about class 3, and as you know, 95% of the class 3s are related to the maxilla, so we should create something that expands the maxilla and help us to solve this kind of class 3s. So we should also work with aligners. Expansion is really, really great with aligners. And about the habit, it's not easy with aligners, as it is not easy with braces. I always like, when I speak about habit correction, I always like to work at the same time with psychologists, because many children have problems and we need to help them solving the problems before we take out the habit. But there are some conditions that we need to have if we want to start an Invisalign first treatment. For example, we need at least to have the upper centrals erupted, and if it is possible, also the laterals, and we need to have at least the molars. Because if we don't have these tooth already erupted, it will be very difficult to get retention of the aligners. So I will give you today some tricks also on how to get a perfect fitting of the aligners in very small children. I can also share with you, I know that there's an American doctor, Barry Glazer, that is working on very, very, very small children, for example, with 5 years old, and is using aligners on them. Probably in a few months, we will have some cases that he will share with us talking about it. So don't forget, we need to have the molars completely erupted, at least 4 millimeters of the crown where we can put an attachment. We need to have at least 2 incisors erupted, but it's better if we have the 4 incisors. And at least we need 1 permanent teeth per quadrant. So we will need the molars to help us on the fitting, as I told you, okay? So when we talk about aligners or traditional approach with braces, it's completely different when we speak about comfort, because for the kids, there's no problem with aligners. Hygiene, which is amazing. You just take out the liner and you can clean your teeth as you don't use any appliance. Sometimes the aligner breaks, and I will show you where and why. And there's no emergency appointments. So that's why I told you that my life completely changed. Because nowadays I don't have any emergency appointments in my clinic. So every weekend I just stay home, no problem, because I have no mother calling me and saying that the braces has just fallen, the arch wire is breaking, the gum, something like that, okay? So, as I told you, there's a lot of problems that we can solve with aligners. And also Invisalign is now doing a lot of studies and publishing them. So this is one of them where after treating 600 patients, they just take the opinion of 54 doctors. And really the experience was really amazing. I have finished now more than 80 kids with Invisalign First, and my experience is also really, really good. For example, when we talk about expansion and how to do it, this is really a big change in the way we think orthodontics, because when we put an arch wire on a kid with 8 years old, for example, we are expanding the same on both arches, on both sides of the same arch. And for example, if you have a crossbite on one side, using aligners allows you to decide how much exactly do you want to expand. How do you want to do that expansion? Do you want a bodily movement? Do you want just positive torque on crown? How do you manage it? And it allows you to just do not move one of the sides and move the other. So it's very easy to correct a crossbite. So it's completely different, the biomechanics that we are using with aligners compared with the one that we used when we used braces. So I will go on that during this presentation. And of course, this is not new. So it's obviously that when we work as early as possible, when we change the bone, the basal bone, we will have better conditions for our patients to grow. So should we increase the arch size in small kids? Yes, we should. And I will show you today how I do it. So for example, here is a treatment where we start with 29 millimeters between the molars and we end it with 35. So there's 3 millimeters of expansion in each side only using aligners. So it's a lot. And some doctors, some of my students ask me, how much can I expand with only aligners? And usually on my IDS preferences, I ask for expansion between 4 and 6 millimeters. But in many cases, I know that I can go forward. So after reaching these 6 millimeters, if I see that I need a little bit more, I just rescan the case, redesign the clean check, and ask, for example, for 2 millimeters more. And I will show you today, is it possible? Yes, it is. And more than that, it is completely predictable. So, when we talk about dental alveolar expansion, don't forget that if you are moving the tooth, you are always moving the bone around the tooth. So, are you creating bone? This is a big discussion that we could have. But the thing that I just want to say is, if you have a correct diagnosis, if you understand why do you have the crossbite and how can you treat them, you can do everything with one aligner, okay? So, this is my son and my daughter, and I will show you her case because it's a quite beautiful case, I think. And the thing is, they are all, of course, because I'm an orthodontist, because we have aligners at home, because my wife is using aligners, they all want aligners. But it's really incredible because when you start treating kids, for example, when I start treating my daughter, I think it was 1 year and a half ago, I got all her friends from school because the parents were, wow, what is this? How is possible an aligner make this change on her? And I will show you today. So What kind of situations can you treat on a small kid with aligners? Anterior crossbite with less than 3 teeth, okay? 3 teeth. Posterior crossbite, 1 tooth per quadrant. Sometimes, and I will show you, we treat cases with many teeth in crossbite. But if you follow the goals of Invisalign, they say 1 tooth per quadrant. Crowding cases, constricted arteries, spaces, ectopic tooth, protruded teeth, and mild to moderate open bite. So we will cover all this when I come into the clinical cases, okay? And then, of course, because we are orthodontists, we know that some cases are difficult to treat with aligners. So if I have a very big open bite and I think that it is impossible to treat with aligners, I can use, of course, braces or other appliance. But when we are speaking about kids, really, I don't remember to refuse a treatment because I want aligners. So I'm doing everything with aligners with very good results. So now let's focus more on how to plan the case. What are the tricks and the tips that I can give you to create a perfect clean check? Let's go on staging patterns. One thing that is really good is that you can choose which tooth do you want to move. So for example, you can choose for this pattern, molars move first. So for example, you can choose that in every expansion you are doing, you want the molars to move first and then you will move all the arch. Or you can choose to move all the tooth at the same time. And I will explain you why and when do I choose one of these patterns. So let's see this on the right upper arch. So we want to solve this crowding and we want to expand. So let's imagine that we are expanding only the molars. What is the effect on the incisors if you just expand the molars and do not move the other tooth? So don't forget that when you are using aligners, you can choose not to move some teeth. So for example, in this case, I choose to move the molars first. And what will happen is that I will not have any problems on the position of the incisors. So let's imagine that this patient was a class 3 patient. And imagine that we want the incisors to go forward. We want a better AP position of the upper incisors. If we just move the molars, we will not have any side effect bringing the incisors back. So this is really good. But let's imagine that this same patient was a class 2 and that I want to get the incisors back. If I want to get the incisors from back, I will do the expansion all at the same time. So if you expand everything at the same time, you will lose the AP position of the incisors. If you want to expand the molars first, you will not have any side effect on the incisors. And this is, for me, one of the best advantage of using aligners, because with arch wires and braces, you are moving all the teeth at the same time. Do you understand the difference? So, another thing that you have to learn, and I always like to stay focused on this, is let's imagine that you want to play piano. If you want to play piano, you will have to learn how to read music partiture. So if you want to use Invisalign, you have to learn how to read the staging. And that's exactly what we have here on the right side. So as you can see, we are moving the molars first from aligner 0 to aligner 19, and we are moving the incisors at the same time. But if you see the molars and the premolars, they are not moving at the same time. So this is a molar moving first pattern. And this is what I recommend you, for example, if you have a class 3. So this is our music partiture. So it's very, very easy to expand, for example, 2 millimeters if you have all the arch blocked. So if you ask the technician to do not move any teeth except the molars, it will be very easy, the biomechanics of this movement. It will be very predictable. So as you know, each aligner will move 0.25 millimeters. So after 4 aligners, we will have 1 millimeter of expansion. And after 8 aligners, we will have 2 millimeters. So in only 8 weeks, you will get the 2 millimeters that you asked for. So it's really, really easy and predictable. Okay, so now let's imagine, as I told you, that we are moving all the tools at the same time. What is the side effect? The incisors will come back. So we will lose the AP position of the incisors. And as you understood, in some cases it is quite good, in other cases it is quite bad. So it's all about orthodontic diagnosis and what are you asking for. Don't follow the technician. You have to decide all your treatment plan. And here in red, imagine that this is an arch wire. So if you just put a 0.1490 wire, you see that every tooth will move at the same time, so the incisors will come back. It's really different. So if you really want to have a different AP position on the incisors, ask for simultaneous movement. If you don't want, ask for molars move first. With aligners, you also have more torque control and more tipping control. And this is also a quite change. Don't forget, for example, imagine a case where you have space between the upper incisors and you are using braces. You only can close the space after you have a very big arch wire. So usually you use a power chain when you put like a 1825 or a 1925 arch wire. Using aligners, I can start closing the space from the really beginning because I have a bodily movement. So imagine that you have a small kid with a diastema, you can just close it in a few weeks. So nowadays, any case that I consider to use, for example, Damon's system with the degainer or simply the 2-4 appliance, I prefer to do it with aligners. And if I want dental alveolar expansion, in my opinion, is more predictable using aligners. Then we go into the smart forces. What are the smart forces? What are the attachments? How do we manage them with kids? So basically, the system will automatically provide you the best attachment to move one tooth. One trick that I can give you is when you are talking about small kids in mixed dentition, and because the crowns are really small, you need to put attachments in all of his teeth. So you have to book a big appointment the day you want to put the aligners on, because we are talking about a kid. It needs time, it needs collaboration. So I will show you how I do it, but don't forget to ask for attachments for all his teeth. And sometimes we use these optimized attachments that are really good, designed for each teeth, based on the crown of each tooth. They design specifically for that crown. So they really work. But sometimes for some movements, I change the optimized attachments for conventional attachments, especially on the molars. If I need to disrotate the molars, I prefer to put rectangular horizontal attachments 5 millimeters. So if you can take a note, just put that on upper molars. If you want to disrotate them, ask for rectangular horizontal attachments 5 millimeters. And one of the problems that we have when we think about braces is the short clinical crown. So it's not easy sometimes to use braces in a small kit. With aligners, we don't have that problem, because even in very small crowns, they will do a very small attachment, perfect design for that tooth. So I recommend you to use them. Here on the left, you have an example of different tooths with different optimized attachments, every one designed for each tooth. Look at the canine, a very big attachment. That's because they are planning any movement that will need the aligner to be completely fitting. And aligner fitting is something that you have to take care, because if the fitting is not perfect, the movements will not go perfect. So sometimes we have attachments only for retention of the aligner and other attachments for a specific movement. So if you have problems with attachments, if, for example, one attachment falls, the patient will feel it and will tell you, doctor, the aligner here is not fitting. I just feel the movement. So can you just see if everything is correct? Nowadays, because I am using a lot of dental monitoring, I can monitorize all of this. So if I have some problem with any attachment that just fall down, I will get a message on my phone advising me that we have to call the patient. So don't forget that retention is one of the most important things when we talk about attachments. Every year or during every year, Invisalign is launching new protocols, new attachments based on our opinion, based on our cases. And for example, the G7 and the G8 are the latest improvements, and the G7 is a very big attachment that we use usually on the upper laterals, and it is really good to control the tipping. So, and what about the permanent teeth that are just erupting, and how will we manage that with aligners? So they have one feature that they call the eruption compensation. What is that? So basically, it's like a pontic where the tooth will just erupting and come into the aligner. And in 90% of cases, they really work. What is more important is that this eruption compensation is always made by artificial intelligence. So basically, they will understood. For example, if you miss the upper laterals, they will look into the upper centrals, and the artificial intelligence will imagine how long does the lateral will be. And they will design a eruption compensation, and usually it works. Sometimes not, and we have to rescan the case. And because we are talking about rescan, it's impossible for me to treat kids without scanners. So I use the iTero scanner, but you can use whatever you want. But treating kids doing impressions on PVS is really, really difficult. So I advise you that nowadays you should all use iTero scanner or another one to get your cases and to have the possibility to anytime just do a refinement, ask for your new aligners on a very good experience of your patient and not a bad experience of doing PVS impressions. So, as I told you, all these eruption compensations are made by artificial intelligence, and we can do it on incisors, canines, and premolars. Usually the system will put them automatically. The only teeth that is not available is the lower incisors. So usually we don't start any case without having the 4 lower incisors erupted. But if you have problems on that, you will have to tell them. So, for example, I want eruption compensation of 5 millimeters for the lower incisors that is missing. You have to help them, help the technician to do it, okay? Because the artificial intelligence will not do it. So, for example, here is a case where is a missing lateral, so they just put the eruption compensation for that lateral. And then the tooth will erupt and just go into the aligner directly on the eruption compensator. Look at this case. I will show you after all. This full case is a very interesting case. The patient has a diastema and he doesn't have space for the lateral. So we start closing and we ask for the eruption compensator for the lateral. And then he just starts erupting and will go into the aligner as soon as possible. You don't have to put any attachment, just wait and let them go. Here it is, the aligners, look, the lateral will go into the aligner with nothing, so we just erupting, we don't have to do anything. So, about timing, this is really important because it's very difficult sometimes to decide if we should start now, if we should wait. So I always ask you to do a panoramic X-ray and understood in which direction should we go. Because if we have a lot of tooth coming out, maybe you can wait a little bit, wait until the eruption begins and rescan the case and ask for the aligners. If you want, for example, a big expansion at the beginning, you just scan the case, do it, and you know that probably in 1 month you will have to rescan again because some tools are just erupting. So that's why I think that working on kids without using scanners is really, really hard. So about the clinical preferences that I ask when I am using aligners. IPR. In my preferences, I have the option no. Because if you think about a small kid, I don't want to do IPR on his tooth. So on my preferences, I ask for do not do any IPR. And if sometimes I need, in some case, I will do it myself. But on my preferences, I prefer not to do IPR in small kids. Another thing that I can ask is expand primary and permanent teeth or just expand permanent teeth. I always ask to expand both, all of them. Why? Because I like to change the arc shape from the beginning. So I can choose the pattern, so I can choose to just move molars first and then the primary teeth, or move everything at the same time. But I always move all the tooth, okay? But if you don't feel comfortable to work on primary tooth, no problem. You just ask for expand only permanent teeth. Everything is possible. This is just my options, but you can manage them for each case as you want. And don't forget that Invisalign will not say anything to you. You are the leader, you are the orthodontist, so you manage your case as you want. About the expansion, on the preferences, as I told you before, I always choose between 4 and 6 millimeters. But you have the option to choose between 0 and 2 2 and 4, 4 and 6, 6 and 8, or more than 8. But don't forget that the technician is not an orthodontist. So if you ask to expand 10 millimeters, on your clean check, you will get 10 millimeters. But you know that in the mouth of your patient, you will not get that. So be careful on that. Then we have to deal with the tooth size discrepancy. What is this? Because we are talking about small patients on mixed dentition, we know that we need to leave some space, for example, for the canines that are coming at 12 or 13. So I prefer always to leave the space around the primary canine. But there's an option of, for example, leave the spaces distal to the laterals, or just leave the space around the laterals, or do IPR on the opposite arch and do not leave spaces. So everything you can ask for, you just have to be careful and take care of your diagnosis. Then we have the staging patterns that I told you. These I always change, and I will show you cases today. And there are some clinical preferences that you can use on adults, but they are not allowed on kids. Very easy. If we talk about incisal edges and gingival margins, of course, if we are talking about kids that are erupting tooth, it doesn't make sense to level the gingival margin. So we have just to level the incisal edges. So this option is not allowed when we are talking about kids. Also, you are not allowed to make extraction of tooth, permanent tooth. Doesn't make sense. So if you want to do extraction, you will extract primary tooth. But if for any reason you want to extract a permanent tooth, on the question 11, when we are doing the case, we can ask them for anything, and I will show you today. And about the special instructions, if you are prescribing Invisalign first, you will have a special form for Invisalign first, so you will not have the option of special instructions. You are not allowed also to ask for Pontics because you have the eruption compensators. So no problem, it's exactly works the same, so we are not asking for Pontics. So after this theoretical approach, I just can tell you that for me, it has been until now a very, very, very pleasure experience working with Invisalign on small kids and completely changed the way my clinic was growing. So now we will go on I think we have done 1 hour, and now we will go on our clinical cases, and I will show you all the steps to start a new case and show you this first case from the beginning till the end. It's a very special case for me because she's my daughter. So I think that if I treat my daughter with aligners is because I believe more than 100% in aligners for kids. So I will show you every step and how do I manage it. So first, diagnose, no doubt. So this is Mariana, my daughter. We just take some pictures of her face. She is a dolichofacial patient with a class 2 retruded mandible. I don't, because probably she's my daughter, so for me she's beautiful. I do not have the perception of how bad her incisors were, but when we do the cephalo, you will see, wow. So she has a class 2, protruded lower incisors, protruded upper incisors, mixed dentition, very big midline deviation. Look, the lower midline is here and the upper midline is here. So we have like 2 millimeters, 0.5 of deviation, class 2 on the left side. So should we treat her? Should we not? How will we treat her? Upper arch She has many breather problems. She almost breathes by her mouth. This is her panel. And look at the lower incisor. Oh my God. How can I treat this? So the mandible is growing down. I don't like this position. So let's see the cephalo. Look at the lower incisor. The upper incisor is not so bad, but I really don't like this lower incisor position. And of course, look at this. 102. Oh my God. I have to treat her as soon as possible. So we start the treatment plan. So basically you will open your IDS site, put her name. Here I just put some of her problems, photos, intraoral photos, extraoral photos, as you know, cephalo, panoramic. I just put her intraoral scanner and we start the case. So this is child treatment, Invisalign first clear aligners. We just press yes, and we decided to treat both arches at the same time. No problem in moving any tooth, and they can put attachments everywhere. Then we decided how to treat this class 2, because we want to improve this class 2 and we want to get a perfect class 1 on canines and molars. So for example, we asked for a first clean check using class 2 elastics if it is needed. About the overjet, I just asked them to align, and after we see which overjet will we get. About the overbite, exactly the same. I did not ask for any bite ramps. So I told them that the upper midline is deviated to the patient's left and she doesn't have any crossbite. So I need to improve the midline, to improve the overjet, to bring the mandible forward. There's a lot of things to do. So after this, this is for me one of the most important questions. So we ask to expand the upper arch, no pro-inclination. And this is very important. This is a big difference between treating a patient with aligners or treating a patient with arch wires and braces. Because if you put a 0.14 night high wire, you will always get some pro-inclination. So with aligners, you can ask to 0 pro-inclination. On the lower arch, I asked also to expand, to do not procline. And of course, because she's my daughter, I don't want any IPR. Extractions, we will not do it. Eruption compensation, yes. I need compensators for the 13 and the 23 that are almost there. And then we go to the last question. I want attachments on the liner 1 because she's a kid, so we cannot treat her without attachments from the beginning. And I asked them to move the upper midline 1.5 millimeters to the patient's left without IPR. So there's a lot of information for the technicians. Now we have to wait for the clean check, and here it is. And I want you to please focus on the clean check. So this is what they send us, 29 aligners only. Let's press the play button and see how are they solving it. So expanding the molars, then molars first, then they are expanding all the arch, changing the arch shape and retruding the upper incisors. And on the lower arch, we can see it here. Let's see the superposition. Look at this. Expanding, retruding, changing the arch shape, creating space for the tongue. So, for the ones that are hearing me, I don't know what is your opinion, but maybe some of you would like this clean check because we will have a better arch form. We will retrude the upper incisors that were proclined at the beginning. So maybe some of you could accept this treatment plan. And I can tell you that there is a study proving that 75% of the doctors around the world accept the first CleanCheck. And I can give you my experience. I have treated more than 600 cases with Invisalign until now, and I have never accepted the first CleanCheck. Never. So, let's go back and think about my daughter's profile. And if you look at the maxilla, and if you look at the nasolabial angle, it is okay. So should we retrude so much the upper incisors? I think she will just lose all her upper lip. So if any doctor does this to my doctor, I will kill him. So should I do it? Okay, so should we approve it? No. Let's go back. And this is probably one of the most important slides I can share with you. And if you want, you can take a picture of this. This is how I speak with the technicians. So look at this. Hello, team. Please do the next changes. First, how will they know the final position of the upper incisors? And I always explain this to every doctor. Think that you are talking with a 10-year-old boy. Okay? You just know how to manage a computer, and you will tell him, please, the final position of the upper incisors will be on aligner 4, position 4 of your CleanCheck, follow the position of tooth number 21. Anyone can understand these sentences because I am saying, okay, we start here, let's go aligner 1, 2, 3, 4, stop. Follow the position of tooth number 21. So they know that I want all my upper incisors at the end of the treatment on the position of aligner 21. Then I told them what I want to do with the upper molars. Follow the position of aligner 8. So these rotate only until aligner 8 and stop. This is the final position of the upper molars. Then I do the same for the lower incisors. So I am giving all the informations so that any technician that pick up this CleanCheck can change it. And then I decided to do not use elastics and go with the mandibular advancement device. So after finishing this first pre-MA phase, stop, put mandibular advancement feature on the aligners, and go until we get a perfect class 1. But because the technician doesn't know what is a perfect class 1, and I know that with aligners, I always have to over-treat to get a good treatment in the mouth of my patient, I ask them, after finishing the mandibular advance, I want to finish the case edge to edge. So I want to go from a class 2 to an edge-to-edge position because I know that after this, in my daughter's mouth, she will have a perfect class 1. So I hope you understand this. You are not asking questions, but if you want, please do it. And this is completely different treatment. Let me show you the second CleanCheck I asked for. So now we have 40 aligners, so we came from 29 to 40, but let's see how they design it. So 1, 2, 3, 4, 5, 6, 7. Okay, now we go with mandibular advancement. One step of 2 millimeters. I want to follow the edge-to-edge position. I want to get perfect arp shape, but I want the profile to be improved. I want my daughter to get a protruded mandibula. So I want the mandible to go forward. And I will show you after the treatment how she is. So then we accept this treatment. We just ask for the aligners. And after 2 weeks, we got the aligners at the clinic and we will place the attachments. Another tip or trick for you when you are working with kids. Don't try to do all the attachments at the same time. So I just do it quadrant by quadrant. So I just cut the template and I do first upper right, then upper left, then lower left, then lower right. So the patient has time to stop, wash his mouth, just stop a little bit, and then we restart, do the other quadrant, and this is the way I have to achieve a good result. And because they are all crazy about colors, I am doing now attachments on color composite. And this is really amazing. Every kid in my clinic are asking for this. And I love when they come back into the clinic and they have one aligner broken. Perfect. I know that they are using them. This is really what I want. Or when they come with aligners like this yellow. Perfect. They are drinking with the aligners. That's exactly what I ask them. I always ask 22 hours with aligners, please. Okay? And for the fitting problems, I love to use the Chewies. So I gave them Chewies, and 10 minutes every day they will be with the Chewy in mouse, just to get a perfect fitting. So let's see with my daughter how things happened. So we start the treatment, the canines start erupting, we start retruding the incisors, we go on retruding the incisors, then we go into the mandibular advance, then comes the COVID, she stay at home, and I ask her with dental monitoring to continue monitoring the treatment because we are not going into the clinic. So it really worked well. And see the profile, we are improving the profile. Continue the treatment. We just reach now a class 1, some midline deviation yet, but we still have space to do it. The upper incisors are now on a very good position. The lower incisors are on a very good position. So just follow the aligners. And then we ask for a refinement. Why? Because the tooths were erupting. So the compensation, the eruption compensators are already done. So we have to ask for new aligners, including the canines on the aligner. And after that, we see that we have a very good class 1 position, so we can finish the case only with class 2 elastics, and we don't have more the MA phase. So let me show you these ones. Okay, a little bit more of intrusion on the upper arch, and you see here perfect class 1. Use a little bit of class 2 elastics to finish the case. And now the left side, almost done. Okay, perfect. Look at this. I use the elastic in this case directly to the canine, to the aligner, not to a button, because I want to lose torque on the upper incisors. So this is all about biomechanics. So 19 aligners more, and look how Mariana is getting perfect. So she is now on aligner 18. I just need one more aligner to finish the case, and then she will go into retention. And I have a perfect class 1. But the most important thing, look at the arch wire design. The most important thing is the profile. Look at the mandible. Big change on profile, big change on torque position, change on the arch design, expand a lot on the upper arch. So I am really happy with this treatment. Look the difference on the profile, and my daughter is now only 11 years old. So I think we reach a very, very good result on her. And because she loves TikTok, now she's
inside of me. I tell them where to put it, never tell them where I'm about to be. I run down on them before I have a nigga running me. Talk your shit.
Okay, let's continue showing you more cases, more tips. And now let's go into a crossbite. So let me present you this little boy, 8 years old. He just came into my clinic because I am treating her sister, her mother, and her cousin. So all the family is already in my office, and all of them are class 3 treatments. So her mother came into my clinic because she knows that everyone in family is class 3, and she saw that Bernardo, who is his name, has a crossbite on the upper incisor. So he decided to come into the clinic and follow the treatments that I have been doing to her sister and her cousin. And this is one more time what I think is really important for you to understood is that if you start treating kids and you have good results, parents will totally agree with your opinions, and you will grow and grow and grow your aligner treatments. So, as I told you, he was 8 years old, anterior crossbite, and when he came in, I thought it was a very easy case. I just do not like the profile. You see that the nasal labial angle is quite open, which means the maxilla is a little bit retruded. So we have to take care of these incisors. About the face is not so bad. It doesn't have any gummy smile. I don't like these black buccal corridors. So it just means that you need expansion. But if you look at the intraoral photos, it looks like a very, very easy case. And sometimes when I'm showing cases like this, some doctors just ask me, but in a case like this, a so simple case, why are you using aligners? And I always say the same. Why should I not use aligners? Because if you want to use aligners, you have to use it for all of your patients. So just do not treat the easy cases with aligners. Treat all of them, okay? And I always like to please ask you to focus on the position of the 31, the one with the crossbite, and look at the gum. She's in a very bad position, and I want you to look at this during the treatment. So we just scan the patient, we have to do the treatment plan, but we have a very bad surprise. When we ask for the panoramic, look what we found. So we saw that we have a missing lateral, the 1.2. We have a very special lateral on the other side, the 22 is a conoid tooth, a very small one. So how to deal with this when we have a class 3 tendency patient missing one lateral, the other one is a very small tooth? How should we treat it? And this is very important to understood. So we have a retrusive profile. As I told you, I don't like this angle, small upper lip, and skeletal class 3. How will we treat this? So I decided to use aligners. I decided that my goal will be better profile, upper lip design, try to bring the upper lip a little bit forward, smile expansion and take out the black corridors, correct the crossbite, center the midline, close the space of 1.2 with the cannon, and design a provisional crown for the 22. So let's see how we did it. And now I would like you to take quite focus on the treatment plan, because there is some mistake in this clean check. 23 liners, expanding, okay, so do you remember when we talk about staging patterns? So this is a class 3 where we want expansion, but we do not want the incisors to come back. So I do not want to change the AP position. And if it is possible, I want the incisors to go forward. And we didn't do that because, unfortunately, we accept this clean check with moving all the tooths at the same time. So the staging is not correct, and we will have problems during the treatment. I will show you and how to solve them. Okay, so 23 liners, some power ridges. We accept all the optimized attachments. Okay, look, everything moving at the same time. And the incisors coming back. It's very important to use the grid feature when you are planning, because it will explain you exactly the changes that you will have. So look at this pattern. We are moving these tools too early on a liner 3 or 4, and we should only move it at a liner 10 or 15. So these are the attachments, optimized attachments, and we start the case. Of course, in crossbite, it is very important to have space. So it's quite good when you use aligners, because you have always 1.5 millimeters of disocclusion, because each aligner has 0.75 millimeters. So it really works on crossbites. So we just start the case. We do 18 aligners, and look at this. Look at the gingiva. As I told you, the gums are really better now. We just correct the crossbite. We maintain the laterals, and our goal was to maintain the lateral as much time as we can. But I don't like the expansion, so we need to ask for more expansion. Look at the gum, just because we correct the crossbite. On only 18 weeks, it's really, really fast. So we improved a little bit. It's not done yet. But because he is a boy and he is a football player, we had a problem, accident. So we just lost the 62, and the 52 is always with very, very big mobility. So my pediatric dentistry just asked me to wait 3 months. We wait 3 months with no aligners, and look, here it comes, the 22, a very, very small tooth. So what should we do now? Should we restart? Should we wait? So we just see that the 52 will also come out very soon. So we decided to continue. So I wait just a little bit more to the eruption of the 22. I asked my pediatric dentist to do a small restorative treatment of the 22, and we decided to rescan the case. The upper lip is a little bit better, not perfect, but better. And then she did this small restorative treatment on the 22, and we lose the 52. So now we will rescan the case, ask for a new staging pattern, ask for a new clean check. And this is very, very important. Look at this clean check. It is really different. First, expand the sticks during 7 aligners. Then expand all the other tooth. Do not change the AP position of the upper incisors, and we will have a perfect arch design. 25 aligners. Look at this. It's quite different. This is one of the most important things that I want to tell you today. Focus on staging patterns, and you will have perfect treatment with less refinements. So here we go. Better now. Expanding the upper arch. I like this arch design. Continue our treatment, expanding more, creating space for the canine, and of course I will this canine let them stay here, just bring the other tooth to the position of the lateral, and then one day when we lose this one, we will distalize the canine and put an implant here. And look how his face is improving. I like this arch design, and this is exactly how we are today. I like the upper lip. We have a 90 degrees now nasal angle, better condition, and now we are just changing the lateral sectors. The premolars are erupting, the canine is also erupting, so we will now wait for the stage 2. Okay, let me just, I will put this case to the end because it's not so important and I don't know if we will have time to do it, so I prefer to show you a difficult one. So let me show you this one, a crowding case. So his mother came into the clinic. She was really upset with him because she saw that he has an upper lateral incisor just behind the upper central. The profile was not so bad, but there's a lack of space and there's obviously a very, very big midline deviation on the upper arch. So let's check the intraoral photos. We have also mixed dentition, compressed upper arch, no space for the lateral. Look, the lateral is just behind the upper central. So we just scan the case. We see that this is really a very narrow arch, and some doctors asked me why didn't we use here some appliance like an IRAX, and yeah, it would be possible, but it doesn't have a cross bite. So I prefer to do it only with dental alveolar expansion. But we have to be very careful because it's not easy to bring this upper lateral to the arch. So we ask for the first clean check with 26 aligners. On this clean check, you can see that I change the upper molars for rectangular attachments because it's a very big movement, so I need a perfect fitting. And that is my advice for you on upper molars, rectangular attachments, as bigger as you can. You see, we are expanding all the tooth at the same time, creating space, bringing the lateral in. And I will explain you what is difficult in this case. So you see that we are moving the molars first, then we are moving all the other tooths. Here are our attachments. So I changed this one for rectangulars, okay? Rectangular attachments on upper molars. We have to teach him how to put the aligners. It's very important to lose some time explaining them how to do it. I will just pass this movie because it is in Portuguese, so it doesn't make sense. And here we go, starting our aligner treatment on day 1 with the canine erupting. We have the eruption compensator on the 13, and we start our treatment. Then it came back on aligner 4. You see that the canine now is just inside the eruption compensator, which means we will have problems here because we will need to rescan. The lateral is a little bit better, and don't forget that because we have the aligner, we open a little bit the bite, which make easier the lateral to come in front. Sorry. So aligner 1, aligner 4, aligner 8. So we are just changing. Look, the 63 is already gone, but we continue with the same aligners because the fitting was really good. So it will work like an eruption compensator, no problem. Aligner 12, changing all the tools at the same time. Look at the midline. The improvement of the midline is really, really great. Aligner 16, the midline is almost done, but we still have lack of space for the lateral, and this will be our problem until the end. And on aligner 16, we understood that, okay, now it's time to rescan because there's a lot of changes. The premolars are already erupting, so let's change the aligners and ask for a new clean check. Look, the changes in only 16 weeks, which is really, really fast. The midline is almost correct. The black corridors are gone. The upper arch is really expanded, and we still have a lot of crowding, a lot of time to work, but we are only on aligner 16. We still have a very good profile, and we ask for new aligners. So we just send them the photos, 26 more aligners. Let's do it. So we are expanding, moving all the teeth at the same time, bringing the lateral in, very lack of space. And for example, I can use this case to explain you the difference between IPR programmed that we ask Invisalign for IPR on tooth number 11, 12, 22, whatever we want, or the non-programmed IPR. What is the non-programmed IPR? So basically, if we don't have space for the aligner, I just ask you to try to pass something between the tooth. For example, dental floss, you just put between 11 and 12, and you will see that you don't have space. So you can do like 0.1 or 0.2 of IPR, non-programmed. It is not on the CleanCheck, but it will help you a lot on bringing these tools to the position. And I didn't do that on this patient, so I will have problems on the lateral, and I will show you in a few minutes. So we ask for new aligners, we redesign the case, the upper canine now is just coming down. Aligner 5, continue expanding and correcting the bite. We are on a class 2 on the right side. On the left side, we are almost reaching a class 1, but we still have to change that premolar. So let's continue doing aligners. Aligner 15, look the difference on aligner 15, because on the right side, I have a perfect class 1 on the premolar. So the canine has space to come in, so things are getting easier. And even on the left side, it is better the position of the canine, so I know that I will reach a class 1. The midline is almost perfect, so I continue with problems only on the upper lateral. And here you see here that we have lack of space. So we don't like to do IPR on kids, but in this case, we should have done it. And if I start this case right now, I will ask for IPR between at least 1.2, 1.3, and 1.1. So we continue, the profile continues perfect, the smile is improving, his mother is really enjoying the treatment. Look at the right side, almost a class 1, perfect class 1. On the left side, we still need to improve. Just continue going on with aligners. His face is changing, of course. The upper centrals are really good now. Let's continue. And for me, the big thing and what is amazing is that we don't have to do anything. We just have to give them aligners and plan the case at home, nothing more. So look at now how is this patient. Perfect class 1 on the right side, perfect class 1 on the left side. The incisors and the midline are perfect, and we just need a very small movement on the tooth number 12. That has been also our problem from the beginning. But the occlusion is perfect, the arp shape is perfect, and I know that this patient will finish on a perfect class 1. So we just need here a little bit of IPR. So what I did, I asked for new aligners. So you see that in kids, we have to rescan a lot. So that's why I advise you to use the scanners, because imagine what is doing PVS impressions every 3 or 4 months. It's very bad for the kid. So this is exactly the last photo I have from him. Perfect class 1, midline perfect, and we will finish this case only correcting the lateral. And I asked for this last CleanCheck, very fast one, just to bring me the lateral to the position. Extrude and protrude a little bit. And I ask to do not move any other tooth because it is almost done. Okay, here we need just to correct a little bit, and then we can finish using a little bit of class 2 elastic if we want, just to improve the overjet. But the most difficult is done. Okay, let's go forward for one more. We are perfect on time. I think we are with 1 hour and a half, so we still have some minutes. Let's see this one, a very small kid. He came into my office because her mother doesn't like the space between the upper centrals, and she thought that the chin is really retruded. Yeah, he's a class 2 patient. So should we treat him now? Should we wait until he is 13, 14? Probably most of the doctors will wait. But there's a breathe problem. And she said that during the night, the noise is completely impossible. So probably this patient will have apnea problems if we don't do anything. So we just look into the intraoral photos. There's a big overjet and overbite, the diastema on the upper arch. You see narrow arches crowding on the lower arch. So we ask for treatment with mandibular advancement. Let me show you how we manage it. Look at the upper incisors because we will close this diastema in very, very, very minimum time. You see, we are using the wings. We will do 3 steps, 2 millimeters each step. We will do 8 aligners for each step. Always changing. Let me just give you one more tip or trick that I like in these kids. Usually, Invisalign asks you to change the aligners every 7 days on kids. I like to do it every 5 days. And it really works for me. And I do it because most of them, after 5 days, they just don't feel anything. And the aligner doesn't fit so perfect. And some of them broke the aligners. So I am changing the aligners on kids every 5 days. Another trick and tip that I can give you today is about the MA phase. Some doctors like to start Invisalign on kids doing the MA phase from the beginning, and I never do it. It's very important to do a pre-MA phase because during this pre-MA phase, this will allow the kid to adapt to the new appliance. So first you will have the experience of using aligners, and then we will teach them how to use aligners with mandibular advance. So at least do like 80 to 10 aligners without mandibular advance. So we start the case, we choose the attachments, aligner 1 with eruption compensator on the laterals, and start closing the space between the centrals from the first day because we have the bodily movement. We have the aligner covering all the tooth. Aligner 4, and after aligner 8, we start the mandibular advance. This is a video I will pass. I will just show you this one because you have to teach them how to bite. They don't know how to bite. So this is something new. You have to teach them how to bite.
Fecha, fecha. Isso mesmo. Abrir.
So I just ask them to open.
Fechar outra vez.
Close. Yes.
Isso.
So
Espetacular.
we have to teach them how to do it. Okay. So in my opinion, this feature of the mandibular advancement is really incredible and allows you to, on a very simple and efficient way, to correct the class 2 in very small childs. So we continue. Look, on after the 12 aligner, on aligner 12, we have the diastema almost done. So he's really happy, and his mother is also happy. So we continue erupting, waiting for the eruption of the laterals. Here they come. As I told you, no attachment, no elastic, just space. Aligner 16 and aligner 21. Look at the overjet and the overbite. We have a class 1 now. So here, look how he is biting with the wings. And because the tools are erupting, I decided to ask for new aligners. And because he is so good biting on a class 1, I didn't ask for more mandibular advance. So just aligners, nothing more. Continue the treatment. Perfect class 1 engagement. Just getting space for the laterals, nothing more. completely change the profile. You still have a little bit of gummy smile, but we will improve it. Look at this. Easy, fast. I don't need to do anything in his mouth. Just see him and give him aligners. Here it is. Very good engagement. Okay, and sometimes some doctors told me about, but there's a small distance. Yes, there is. Don't forget that we have the canine that will erupt and we need to leave some space for that. So, no problem on that. Just let him grow. Continue. The profile. I think we improve a lot. And here it is now. Perfect alignment, perfect arc shape, perfect class 1, big change on profile. So this is a very, very easy way to correct class 2 on very young patients. And this is the message that I want to leave you today. Please treat your patients as soon as possible. There's a question here. How much buccal root torque do I did you put occlusal attachment with this case? How much? Okay, so this is not a question. This is two questions. About occlusal attachments, I really like to use them on adults, especially when I want intrusion of the upper molars. I put on 6 and 7, and that has also the effect of rotating the mandible forward. In this case, when I am using wings, I don't use occlusal attachments. And about the root torque of this case, the expansion, I always like, let me just go back here, if I could, very fast. I can see it probably, let me go back here. Okay, here sorry, let me stop it and go back. Here is better. Okay, so how do I decide about, how do I ask the expansion for the upper molars on kids? So if I see that I have negative torque, I always ask the technicians to expand the upper molars using positive torque on the crowns. And you can, if you want to specify how much, you can ask them. For example, I want 10 degrees more of torque on the molars. When the torque is not so negative, I just ask for bodily movement without positive torque. The only thing I need to advise you here is, if you want to get upper crown torque on the molars, ask always to change the attachment for the rectangular ones. That will control you, not only the torque, but also the tipping. So I hope I answered your question. Let me continue. We are on time. So let me show you now this young girl, which I also treat with Invisalign first. She is just ending her mixed dentition, but she has a nice profile, narrow arch, crossbite, but because she's not so young as the others, I was afraid of using only aligners on her. And I see that this midline deviation has also a lot to do with function. So in this case, because the crossbite on the molar on the left side was big, I decided to correct her before using aligners with an IRAX. So I just scan her tooth, I send to my lab, I ask for an IRAX, I do 15 days of expansion, I open, I think 6 millimeters in this patient, I blocked my IRAX, I wait 6 months, and I ask for aligners. So before we start the aligners, we decided to do an IREX appliance. We open the space and we completely change her arch. So this is her immediately after finishing the IREX. So after that, I rescan the case, and this is now a very easy case to do. So I have my upper arch on a very good position. I have my lower arch. So she is just finishing her mixed dentition, and we ask only 12 aligners to solve the case. And now we have to speak about, this is almost a teenager, and this is a problem because, as I told you, on kids I have a very good experience on compliance, but on teenagers it's not the same. So I prefer on teenagers to do small treatments, small goals, doing many refinements if I need, but try to maintain them with a high level of compliance. And in this case, it was really difficult, and she only has to use 12 aligners. So we start the aligners, very easy. Then we just, the second premolar just start erupting on a very bad position, and she doesn't want to continue with the aligners, so I was having problems here. So what I did in this case, I just stopped the aligners, I put buttons, and with the buttons I correct the premolar before I rescan the case. So this is just to tell you that it's not everything perfect, and when we are talking about teenagers, be careful with aligners because it's not easy always to have perfect results. So we continue the treatment, just finishing the canine on the left side, finishing the alignment, and now the canine is almost done, and we just finished the case using the buttons as I told you. And I think I have here the final photos. Let me check her. So this is her smile now, finishing the case. Sorry. Okay. And here she is now after disrotating the premolar. So very easy case because we did it with IREX first, but it takes me 2 years because of the collaboration of the patient. She was not using the aligners as I asked her. So to finish this presentation and to go on into your questions, I just want to give you my experience when I finished my first 40 cases of Invisalign first, and I would advise you to look at this article on GCO 2019 February that goes a lot the same as my opinion. So basically, what can I say about aligners in kids? It is very good point when it took to speak about hygiene. So I have some problems, and you see that even with aligners, some of my patients have the gums with a little bit of problem. So imagine that you are using braces, and I think if you explain this to their parents, they will understood that it's easy to do it with aligners. Then it comes to comfort, because nowadays patients just do not accept pain. And with aligners, of course, I always explain them that to have movement, you have some pain, but it is not comparable the pain that you get if you use fixed appliance. So these are the most important advantage, in my opinion, of using aligners in kids. Another thing is for you as an orthodontist to do not have emergencies, so you will have a better life. And sometimes one question that the doctors ask me is, okay, but because they are kids, if they lose the aligners, how will you manage it? It's easy. I always say, if you lose one aligner, just go on into the next one. It's not a problem. So there's no other emergency than losing an aligner or losing an attachment, which is not a problem. So on the next appointment, you will just put the attachment on. For the ones that don't have so much experience, don't forget that, for example, if you are on aligner 15 and you lose 2 attachments and you want to put the attachments on, you can ask Invisalign for the attachment template for the aligner 15. And it's completely free. So you just go into your IDS and ask for the attachment template whenever you want. It doesn't have to be on aligner 1, 2, or 3, okay? And because of this experience with high level of results, the patients feel so comfortable that they will recommend you to other patients. So my story with aligners, until 2016, I only worked with braces. And I was doing like 500, 600 cases a year with braces. My clinic was completely full, but my life was very difficult. In 3 years, I came from 0 aligners to more than 500 each year. So it's really crazy, the change. But I just give you my example to advise you to go on it, because you will love this new life. So about how do we control also the patients, and because we are talking about these pandemic times, I think it is still important to make you understood that aligners, in my opinion, is the most safety solution, because I don't have to touch the patients. I am using a lot the virtual appointments, and I am sending directly home their aligners after putting attachments, because I take all the control with my cell phone. The new applications that we have from Dental Monitoring or other brands that allows you to take control of your patients even in pandemic times. So it is really a good experience, and my clinic doesn't stop with this pandemic time. So we continue having new patients, we continue having the patients on board, they don't stop the treatment, they don't have problems. So this is, for me, the best experience I can give you. So about the phase 2, the phase 1, how to manage it, I hope you understood it. So I always do some kind of retention between the aligners. We have some questions here, sorry. Does measurement occur whenever a permanent tooth erupts? No. So basically the artificial intelligence will decide the measurement of the tooth, and usually it works, but sometimes you have to rescan the case and ask for a new aligner if it doesn't happen. I was remembering here a case where I have a upper lateral just came out, but it didn't came into the aligner, it came behind the aligner. So I have to rescan it and ask for a new aligner, now without eruption compensator, but with the tooth included on the aligner. Another question is, why don't you start the aligners immediately after finishing the expansion with IREX? So basically, when I use IREX, it works like 15 days. Then we close the screw, and usually I like to wait about 6 months until the bone is perfect, because when you open the bone on the upper arch, you will have a lack of bone that needs to be perfect to restart the orthodontic treatment. It's exactly the same as you do it with braces. You should not finish the Invisalign the IREX in 15 days and go on with braces. So we need the bone to be okay. That's why. And another question is, when you rescan attachments, stay in the teeth or you change them? Very, very good question. Thank you. It depends if I am rescanning because I am changing completely the treatment plan or just because I need finishing improvements. So if I am changing the treatment plan, I have to take out the attachments. But usually I rescan the patient with the attachments and I just change the attachments when the new aligners are in home. So they can do the virtual cleaning of the tooth. They will do the new attachments. They will send you the new aligners. And then when the patient comes back, you take out the attachments that you have on the first stage. Then you clean everything and you do new attachments. If you are not using scanners for the impression, you should take out the attachments before you do the impression, or it will be difficult to get a very good impression. So, about the expansion, my experience, as I told you, is between 4 and 6. So, very good experience on dental expansion. And in her article, she talks about 5 millimeters. So, it's basically the same. And this, I have already told you, the competitive advantage of using aligners is that nowadays the patients just want to just ask for aligners. I don't have any patients asking for braces. So if you are not in this field, you should be, because I think that on the near future, in 1 or 2 years, the braces will just end. So about the managing parents and managing the fitting and the use of the aligners, I prefer to do it with my APP of dental monitoring. So I have a totally control every week. My patients are doing home scanners every week. So we have totally control on that. But the experience is really good on kids. On teens, I don't have so much good experience. Some of them don't want to use the aligners. They just go to the school and take out the aligners. So we need to work more on how to improve the use of aligners on teens. So I think I am quite on time after 2 hours of speech. So if you want, we can go on questions and answers. I don't know how do you manage it. If you want to put the micros on, if you want to just send me by WhatsApp, as you wish. So I'm here to hear you and to answer any question if you need. Don't know if you have any more questions I can help you. I will just put my Instagram account here if you want to contact me after this lesson. You just have to follow me and I answer any doctor. So any more questions? I'm getting on WhatsApp. No more questions. Okay. So I think we have finished. I hope you enjoy it. And please, if you need any other advice, just send me a private message. And it was a pleasure. Unfortunately, we could not be there. We have to use only the internet to speak. But I hope in the near future I can visit you. And one more time, if any one of you wants to come to Portugal, I'm here for you. Thank you, everyone. Hope you enjoy it. Bye-bye.